intensivecare.com and intensivecareathome.com live stream. My name is Patrik Hutzel from Intensive Care Hotline and Intensive Care at Home. Today's live stream is about, can you live at home with a breathing tube or an endotracheal tube? And want to welcome you to this live stream. So this is a question we get quite frequently, and I want to answer the question once for all, because I think there's quite a few myths about it, and there's quite a few issues around this where people don't have all the answers straight away, and they think when their loved one is in intensive care that they can go home with a breathing tube pretty quickly. So let's look at this closer today. So before we dive into today's topic, what makes me qualified to talk about today's topic? I'm an intensive care nurse by background. I have worked in intensive care for over 20 years. I have, in 3 different countries, I have worked as a nurse unit manager in intensive care for over 5 years. And I've worked in intensive care for over 5 years as a nurse manager. I've been consulting and advocating for families in intensive care all over the world since 2013. I have looked after thousands of critically ill patients in intensive care as a bedside nurse, and I have consulted 400s of families in intensive care that have a loved one in intensive care all around the world. I'm also the founder of Intensive Care at Home, where we provide intensive care services at home for predominantly long-term ventilated patients with a tracheostomy, but also home TPN and otherwise medically complex patients. You're welcome to type your questions into the chat pad, and I'll also give you some phone numbers that you can call on after I've answered all the questions to today's topic, so you can dial in live on the show if you like. So let's dive into today's topic. Can you live at home with a breathing tube or an endotracheal tube on a ventilator? It's a question we get quite frequently. We have often people call us and say, hey, my loved one is in intensive care, they're on a breathing tube, on a ventilator, they're in an induced coma, they're having a pneumonia, they're having COVID, they had a motor vehicle accident, they had a heart attack, they had a cardiac arrest, whatever the case may be, and they want to take them home just after a few days in intensive care. And why do they want to take him home? They don't feel like their loved one is getting the best care and treatment. There's often visitation limitations, in terms of visiting hours, especially with COVID. Some hospitals are still locked down or go in and out of lockdown. And families just feel like it's not the right place. Intensive care teams are often very negative. They're painting the doom and gloom picture. They just simply feel like it's not the right place to be. So I don't have great news here that, families cannot take their loved ones home with a breathing tube at the moment. It's too unsafe, even though we are providing a service, intensive care at home, that you can check out at intensivecareathome.com. When someone has a breathing tube or an endotracheal tube and is in an induced coma, the goal for them should be to be on the breathing tube or endotracheal tube temporarily, and the goal should be to get them off the ventilator, get out the breathing tube, and then go to a hospital ward and then go home, right? So it's not advisable or recommended at this stage to go home with a breathing tube or an endotracheal tube. There is one exception, and I will explain that in a minute. But just to hone in on why patients with a breathing tube or an endotracheal tube in their mouth should not go home straight away anyway. Chances are they will come off the ventilator. Chances are that the hospital is the better place to get them back to normality, get them to recover, and and then going home is so much easier. Because if you go home with a breathing tube, or even if you go home for intensive care purposes, you need a 24/7 intensive care at home nursing roster with ICU nurses, and that can't be set up overnight. It can be set up, over time, but not overnight. Good morning, good evening, Modema, nice to see you again. So, it's not as straightforward as you think. And once again, a breathing tube or an endotracheal tube should be temporarily making going home so much better. By the time we would have set up a nursing roster for someone to go home with a breathing tube, the breathing tube should hopefully be out, and then you don't need a 24/7 nursing roster for home care anyway. So I hope that answers the question. Now, I will dive a little bit deeper on the whole topic a bit later, but I also need to talk about the exception when you can go home with a breathing tube or an endotracheal tube, but you will also quickly understand that you don't really want to be in that exception. So sometimes when patients are in intensive care and they have a breathing tube and or an endotracheal tube, they might potentially be in an end-of-life situation. And if the patient will be extubated, i.e. the breathing tube or the endotracheal tube will be removed, the patient will actually pass away. And if that is the consensus from the intensive care team and from families in intensive care, if that's the consensus, then you might want to start thinking about, okay, if we do this so-called, quote-unquote, one-way extubation, meaning we take the breathing tube or the endotracheal tube out and let the patient pass away, it's a palliative care situation. Do we want to do that in ICU? And I can't tell you over the years, when I worked in ICU, when I've been involved in quote-unquote one-way extubations, how many families have said, well, we have decided that the one-way extubation is the right next thing to do. But how much nicer would it be if we can do that at home? Can't we take our loved one home and do the one-way extubation at home? Can't we have our loved one pass away at home? And the answer to that from an ICU perspective at that stage was no, you can't go home with a breathing tube. Now, that is the exception to the rule. We have done what is being referred to as a one-way extubation, basically taking the breathing tube out with the goal of palliative care, end-of-life care. We have done that at home. That is the exception to the rule, right? But again, you don't want to be in that exceptional situation, really. The goal of any ICU should really be to save your loved one's life, help them to improve, help them to survive. And of course, again, there might be situations where one-way extubation / palliative care, end-of-life care is the best option, but then you should ask, where do you want that? And that's what we can definitely do at intensive care at home. We can definitely help intensive care patients going home with a breathing tube or an endotracheal tube for a one-way extubation for an end-of-life situation, for end-of-life care. And I believe that is the much better choice, to have that in someone's home as opposed to an intensive care unit. If it's somebody's wish to proceed to end of life at home, then I believe that needs to be respected, and the hospitals should not hold families or patients hostage to, this is how we've always done it. No, it's a very special time for families and for patients if it's end of life, and it needs to be respected about what families and patients want. And then a one-way extubation can definitely be done at home. I remember vividly looking after a patient in ICU a few years ago, many years ago, probably about 10 years ago now. He was actually a rabbi of the Jewish faith, and he was in ICU. He was actually dying. He had a massive stroke. He had a cardiac arrest. He was very unwell. If we had extubated him, then he probably would have passed away. But the family's wishes and the Jewish community wishes was that he would be flown back to Jerusalem, to Israel, and have the one-way extubation there, because it was part of their faith. So it's actually transported back on a charter plane to Israel to have the one-way extubation there as part of their faith, and that was facilitated at the time. So I think that's another example that end-of-life care is just not a one-size-fits-all approach. You know, that people have different faith, different beliefs, and so forth. You know, and so forth. Yeah. So that's a little bit more feedback there. We have even done one-way extubation for children at home through palliative care, taking them home from ICU, even neonates. Again, it's very sensitive topics, but you know, again, it comes back to what do families want, you know, and as much as we can't take someone home on a breathing tube for the next 4 weeks, because that would simply be unsafe, because if they can't come off the ventilator for the next 4 weeks, they need a tracheostomy, right? And that's when intensive care at home comes in, if someone has a tracheostomy, you know. That is the bottom line. So I hope that answers your question in terms of whether someone can go home on a breathing tube. You see, if someone would go home on a breathing tube and the breathing tube comes out, it needs re-intubation, right? And that can only be done by an intensive care specialist or by an anaesthetist. Whereas if someone is at home with a tracheostomy, we as intensive care nurses can reinsert a tracheostomy. Okay, so that is one of the main differences. Also, when someone is on a breathing tube or an endotracheal tube, they are in an induced coma most of the time, or they are heavily sedated or on opiates such as morphine, fentanyl, and that requires more monitoring, more invasive monitoring compared to when someone is having a tracheostomy. They're often on inotropes or vasopressors, you know, while they're in an induced coma. It's not to say that we couldn't do that at home, but it just doesn't make sense to do it in the short term at the moment, because when we do intensive care at home, it takes a long-term approach. It is for someone that is tracheostomized, can't be coming off the ventilator for periods of time, you know, and that is the major difference, you know, whereas a breathing tube should be short term, and that's why it doesn't make sense setting up intensive care at home at this particular point in time. If, for example, we had a shortage of work, then we possibly would be looking at that, but at the moment the demand is so high for patients with a tracheostomy to go home as opposed to staying in intensive care long term. That's why it's out of the equation at the moment. Yes, Mortimer, and yes, what's the term? A medical directive, an advanced care directive. Yes, I was going to come to that, but I can bring it up now, that the best way for you and your family to get what you want, to, you know, for example, if you know for yourself or for your mom, for your dad, for your spouse, whatever the case may be, to have it documented up front what you want. You know, if you're in intensive care in an end-of-life situation and you say, hey, under no circumstances do I want to approach my end of life in intensive care, I want that at home with the right services, then that needs to be documented in your advanced care directive, absolutely. It's very important, but I also know from experience very few people have an advanced care directive. It's also very confrontational thinking about, you know, an advanced care directive. What do I want if the worst case scenario hits, and so forth. So, you know, if you type into Google advanced care directive, you should find those documents for whichever country you're in or even your state. But, you know, it is very important to have such a document. Helene, you're asking, is it, and welcome Helene as well, you're asking, is it possible that a breathing tube could be inserted into the stomach instead of the lungs? Absolutely, absolutely. I've seen it, not many times, but I've certainly seen it. And unfortunately, I have seen patients being intubated into the esophagus, which is the connection between the mouth and the stomach instead of the lungs. I have seen, unfortunately, patients coming out with brain damage after that because simply they weren't oxygenated properly. Now, most of the time, you pick up on that pretty quickly because you will see, your ventilation volumes are all over the place. You will, when you listen to someone's chest with a stethoscope, you can't hear any air entry. Your blood gases would be pretty much off, right? If you do a chest X-ray, the X-ray will show that the breathing tube is not in the right place. But even if you pick it up within 5 minutes, it can be too late. The damage might have been done already. Doesn't happen very often, but I have seen it on the odd occasion. And I'm sure it still happens every day, unfortunately. Yeah, that is for real, Modema, unfortunately, it is for real. But as I said, it doesn't happen very often, but unfortunately, medicine, nursing, we're all human. We've all made mistakes. And it's certainly not pleasant when it does happen, I can tell you that much. It's not pleasant. So look, if I look ahead, maybe if I look decades ahead, I do believe that people eventually will be able to go home with a breathing tube and an endotracheal tube, but it's not there yet. I do believe that home care is the future one way or another. We are just breaking the ice here with intensive care at home now, with taking some patients home. But, the concept has been proven. We're doing more and more work. We're having more and more inquiries. And maybe in 50 years' time, maybe in 100 years' time, maybe even earlier, patients will go home with a breathing tube as well. At the moment, I wouldn't recommend it, with the exception of a one-way extubation and end-of-life care. And also, if you are thinking about taking your loved one home with a breathing tube, you should also be thinking about getting your loved one off the breathing tube as quickly as possible. That should be your ultimate goal. That should be your ultimate goal. Okay. Now, if you're not happy with the ICU, and that is your main driver, I do fully understand that sometimes the main driver of someone wanting to go home, irrespective of the critical circumstances, is simply to be unhappy with the ICU, the way they've been treated, the things that the ICU team says, they're negative. Then you probably should be thinking of changing ICUs. But more importantly, you should contact us here at intensivecarehotline.com, because we can actually help you with the advocacy to get best care and treatment for your loved one. Now, Mrs. Moroda has a question. I'm in the MICU right now. My brother had a cardiac arrest. He stopped breathing before the... Hang on. The question disappeared. Just give me a second. He stopped breathing before the EMT got there. They performed CPR to bring him back twice. He's now on the ventilator, unresponsive. We're scared. Yeah, that's understandable. That is understandable, Miss Moroda. It's a very scary situation. I guess no one is sitting at home wondering, what should I be doing if my brother goes into ICU next week with a cardiac arrest? So families are completely unprepared. Now, I can tell you from head to toe what's probably happening there at the moment. They've probably done CPR. They've probably done a CT brain or an MRI scan of the brain to see whether there's any brain damage. He's probably in an induced coma now. He's heavily sedated with a breathing tube. He's on a ventilator with a breathing tube in his mouth. He's probably on inotropes, vasopressors, to stabilize his heart. He might have had an angiogram or an angioplasty in the catheter lab. He might be on a cooling mattress. he might be cooled down to 34 degrees or 33 degrees or even 32 degrees for 24 hours and then be warmed up slowly to protect other major organs. He might be on a balloon pump. He might be on ECMO. I can understand that this is very scary because you haven't seen it before. But that's again, why you are here and why we are here to help families in those situations so they can A, ask the right questions, B, not be overwhelmed by the situation, C, not get bogged down by the negativity of the intensive care team, because I don't know whether the intensive care team has spoken to you already, Ms. Moroda, but they're probably very negative. They're painting you the doom and gloom picture. And I can tell you from experience and also from research that's out there, 90% of intensive care patients survive, right? That's 9 out of 10 intensive care patients surviving. So why would your brother not be in that 9 out of 10? So it's not a hopeless situation, like you say, Modema. It's never give up hope, Modema, you're saying hopefully the concept of med beds will change. What do you mean by that, med beds? I'm not sure what you mean by that. So with all of that said, Ms. Moroda, with you're very hopeful, absolutely. But it really comes down to you now, to you and your family now asking the right questions, because I've given you a brief overview what's most likely happening there at the moment, but the devil is in the detail. You need to also look at blood results. You need to look at what medications is he getting. You need to look at the CT brain or MRI brain scan results. You need to see what's the damage that's been done to the heart, right? Yes, what questions to ask. So, very, very are a bit, no MRI yet, okay. Modema, I have no idea what you mean by med beds. I really don't know what you mean by that. So no MRI brain, no MRI yet, but I'm pretty sure they would have done a CT scan of the brain if he's stable enough. If he's stable enough, right? So the questions to ask again are, how long was the cardiac arrest for? How long did it take them to get your brother back? How long was he potentially without oxygen to the brain, right? Has he sustained a heart attack? What's been the cause of the cardiac arrest, right? Has he had an angiogram or an angioplasty where they put a catheter to the coronary arteries to see, has there been a blockage? Have they done an ultrasound of the heart to determine how much damage there has been done? Are other organs affected? Are the kidneys working? Is the liver working? Are the lungs working? The lungs are probably not working at the moment because he stopped breathing during the cardiac arrest. What medications is he on, right? Has he sustained a hypoxic brain injury, right? Was the cardiac arrest, again, for how long? And if it was for a prolonged period of time, A, chances for brain damage are pretty high. B, chances that for kidney damage are high because the kidneys wouldn't have been perfused for a period of time, right? What does the chest X-ray look like, right? Is he at risk of having seizures with the potential hypoxic brain injury, right? If he is having seizures, how are they managing it, right? What medications is he on, right? Are his potassium levels in order? Is his sugar high? Because a lot of patients in ICU end up at least temporarily with high sugar levels, even though they're not diabetic. It's just simply a stress response, right? Does he need potentially cardiac surgery as part of the cardiac arrest, right? Has he, during CPR, potentially aspirated? Okay, was there stomach content going into the lungs? Is he at risk of developing a pneumonia, right? Does he have a feeding tube? Have they started feeding him? Is he in cooling therapy at the moment? If so, how long is he in cooling therapy? What is the plan there? Okay. When he had the cardiac arrest, was he standing? Was he lying down? If he was standing, Did he have a fall? Did he potentially sustain any fractures from this, right? You can see the list of questions is endless, and asking the right questions is critical, absolutely critical, right? No seizures yet. He has a catheter, it has urine, so I'm guessing his kidneys are fine. Very little corneal reflexes. He has cooling on him, right? Okay. If he doesn't have corneal reflexes, there could be a number of reasons for that. The first reason could be that he's simply too sedated. Okay. The other reason for that could be that he sustained a significant hypoxic brain injury, and therefore there are no corneal reflexes. You are saying he's receiving nutrients, not sure if his body is digesting. You should definitely ask. I'm positive that he is already receiving nutrients. With him being in an induced coma and with him being in cooling therapy, the digestive system is slowed down, so he probably is digesting, but probably compared to a healthy person at a much lower rate, right? So they're probably feeding him very slowly, right? So, and also, Ms. Maroda, the biggest challenge for families in intensive care is simply that they don't know what they don't know, and this is why you're here. They don't know what questions to ask, they don't know their rights, they don't know what to look for, and they don't know how to manage doctors and nurses in intensive care. But that's why you're here, to get all the insights, He was having these jerks, shakes, but they put him on a sedative to stop, lower his, hang on, the question keeps disappearing on me. He was having these jerks, shakes, but they put him on a sedative to lower blood pressure and stop jerks and shakes. Okay, right. If he's jerking, chances are that he sustained some level of brain injury. It's what I've seen over the years, that usually when there's jerking movements, that patients have some sort of hypoxic brain injury, which puts them at higher risk of having seizures as well. You could almost argue that jerking is minor seizures. Therefore, there's a very high chance they would have started him on some anti-epileptic drugs as well, such as Keppra or phenytoin. Very high chance he might be on that as well. I'll tell you what will probably happen in the next 24 to 48 hours. He will probably come out of cooling therapy after about 24 hours. They will then slowly warm him up just by 0.1 degree per hour. He will then most likely have sedation switched off, assuming they've done a CT scan or an MRI scan of the brain. If he's had that, they will probably wake him up and see how he's responding. They will keep monitoring the pupils. And if he hasn't had a CT scan of the brain, or if he hasn't had an MRI scan of the brain, they will probably keep him sedated until he's had that CT scan or MRI scan of the brain, right? So that's probably what is ahead for your brother. If his brother won't show any signs of waking up once the sedation is off, you will need to be very, very patient, because it can take days, weeks, sometimes months, and you will have a very negative intensive care team talking to you in the meantime. So just to be prepared there. And I hope that your brother will be able to come off the ventilator. If he can't and he's not waking up, then you should be considering a tracheostomy as a next step, right? So, but I would be very happy to talk to the doctors directly, or review medical records. We can do a combination of all of that, so you can continue to ask the right questions. Okay. So, and God forbid, Miss Maroda, if you want to go down the track of end of life, which I hope it's not going to be the case, then you might want to consider what I talked about before. Would you want end of life in ICU, or would you want that somewhere else? But it's probably not there yet. It sounds to me like it's very fresh, and you just got to start asking all the right questions. And once you've started asking all the right questions, get all the answers, and then make a decision from there. What's very important in a situation like that is, stay positive. And I know that's easier said than done, but stay positive and, see what happens. But keep asking the right questions. Make sure they know you are talking to someone that understands intensive care just as much as they do, because intensive care teams often play on families not understanding intensive care, and that's how they keep the upper hand, right? It's great that you've written everything down. The video will also be uploaded once we finish here. It'll be uploaded a bit later today, and then you can watch it again, so it won't go away. So I hope that helps. The most important people you need to talk to now is in the ICU is cardiologist, neurologist, and then the team that's probably driving the treatment is the ICU team. But the cardiologist and the neurologist should be having some input here as well. Okay, I hope that helps. And like Modema says, healing takes a long time. And that's also often when patients come out of an induced coma, and they're not waking up straight away, and then someone does a follow-up CT scan of the brain, which doesn't show anything. It simply means that people take their time to wake up. They've just been through a critical illness. It's not like just switching on a light. It's like switching on a light with a dimmer, right? That's what coming out of an induced coma really is. It's like coming out, it's like switching on a light with a dimmer. It takes time, Helene has another question. When someone is ventilated as a standard, should their head be raised, lifted? Hang on. Should their head be raised, lifted, or flat in hospital's bed? How often should the patient receive suction to prevent aspiration? Great question, Helene. In would have been around 2005-ish, new research came out in ICU, basically talking about new goals for patients. There was a term, and I can't even remember now the term, but one of the new, to prevent VAP, ventilator-associated pneumonia, yes. To prevent ventilator-associated pneumonia, also known as VAP, patients need to be at 30 degrees head of bed elevation at all times. Okay, that was new research that came out between 2005, 2010, I can't quite remember. But 30 degrees up to prevent aspiration pneumonia, but also to help patients to breathe up, to normalize, Imagine you're lying flat all the time, right? And how often should a patient receive suction to prevent aspiration? The guidelines are sort of once a shift, like once a shift. The reality is that most patients in ICU need it more often than once a shift, right? That's the reality. But at a minimum, once a shift. That's at a bare minimum. But there's more to that, Helene. It's not only to prevent ventilator-associated pneumonia. There's also things like, you need to start feeding early, okay? Which might go counter to what I just said in order to prevent aspiration pneumonia. But it's a bigger picture evolving here. If you're not feeding early, patients in ICU are at risk of developing gastric ulcers, okay? If you are feeding early in ICU, you go back to normality. You don't need to feed them huge amounts, but you can start on 20 mils an hour, right? Just to get the stomach going, put some normality into the stomach with some food, right? that's all part of the bigger picture, actually, of part of preventing ventilator-associated pneumonia. Okay, keep the sugars normal and all that sort of thing. But head of bed elevation, 30 degrees is standard. Whether someone is on a breathing tube, not ventilated at all, or has a tracheostomy, 30 degrees should be standard, just to prevent that aspiration. Absolutely, Modema, family photos in ICU goes a long way in improving treatment outcomes. Absolutely. An acronym, I'm not sure what you mean with acronym. You may be talking about the VAP, ventilator-associated pneumonia. I'm not sure what you're referring to there. So also, coming back to what you asked just, Helene, a minute ago, to prevent ventilator-associated pneumonia, things like anticoagulation in ICU, to prevent PE, pulmonary embolus, that's all part of preventing a ventilator-associated pneumonia. So, it's often in ICU, it's like piecing together a puzzle. You need to do one thing, but if you do one thing, you also need to do the other thing to cover all bases, right? And that's why it's so specialized. You can't just look at things in isolation. They always go hand in hand with everything else that's going on, right? That's why I keep saying, you don't know what you don't know. You don't know what to look for. You don't know what questions to ask. And you don't know your rights. And you don't know how to manage doctors and nurses in intensive care. And by you starting to ask the right clinical questions, they know that you're talking to someone who understands intensive care inside out, right? So I hope that answers your question. Now, I can see there's still people here. What other questions do you have? Please fire your questions away. We've got some time left. In the meantime, while I'm waiting for your questions, I'll just keep talking about, the complexity in ICU is, it's, it takes years of practice. It takes years of practice. I've worked in the environment for over 20 years, and I still practice now more in the intensive care at home world, but I still practice, and you're constantly learning. You're constantly learning. It's like connecting the dots. You need to connect the dots clinically. Once you connected the dots clinically, then you can start looking into the whole politics. It's a very complex arena. And just because, what the ICU team is telling you, you need to see that in the context of what's happening in an ICU on a political level. You always need to read between the lines, always. Going back to, can you live at home with a breathing tube? No, you can't, not in 2022. I'm sure that it's coming at some point, but at the moment it wouldn't be advisable. And fiscal, absolutely. A lot of it, what's being said to families depends on what the budget in ICU looks like, right? That's what it comes down to. What does the budget look like in ICU? What's their bed situation like? What's their staffing situation like? Sometimes families come to us and they say, when I ask them, hey, what's the ICU like? Is it busy? And then they say, oh yeah, I've seen 4 empty beds, so there should be enough room. Well, I tell you what that means in my eyes. Just because an ICU has 4, 5, 10 empty beds doesn't mean they're not busy. What it means is they have 4 empty beds, which could mean they don't have staff. Think about this. Just because there's 4 empty beds could simply mean they don't have staff, which means all the other beds that are occupied, they're running on the numbers they need for the other beds, but they're probably running on skim numbers nevertheless. The question that people need to ask in ICU, how many staff do you have for how many beds? That's the most important question, right? There's a massive nursing shortage and also doctor shortage in ICU. It's massive all over the world. So, okay. So I want to slowly wrap this up today. I will be, and please keep asking the questions while I'm still here. If you have any other questions, keep asking them. And I will do another YouTube live next week around the same time, around 8:30 p.m. Eastern Standard Time, 5:30 p.m. Pacific Time. Now we've got more viewers here. Please type in your questions, or if someone wants to call in live on the show, I'll quickly put out some numbers. If you're in the US and you want to dial live into the show and ask questions live on the show, the number is 415-915-0090. That is again 415-915-0090. If you're in the UK and you want to dial into the show live, you can call 0118-324-3018. Again, UK 0118-324-3018. And if you're in Australia, you can dial 041-094-2230. Again, for our Australian viewers, 041-094-2230. I'll just keep talking for a little bit longer. So if someone wants to call in live on the show, you can do that now. Okay, so again, very important that if you have a loved one on a breathing tube and you're thinking about, you're not happy with the treatment, you think about how can I take my loved one home, get your loved one off the ventilator first. And if you don't know how to achieve that, and if the ICU is difficult, just contact us at intensivecarehotline.com and we can help you with all of that. We can help you with asking the right questions. We can help you with the advocacy and the consulting for those situations. Helen, you're asking, prior to COVID 2021, how many patients should be assigned per nurse? There's a little bit of a difference from country to country. UK, Australia, it's usually 1-to-1. I do understand that in the US, sometimes it's a 1-to-1, sometimes it's a 2-to-1, meaning 2 patients for 1 nurse. So it depends a little bit from country to country. But I would argue the gold standard in ICU is 1-to-1. That has gone out of the window since COVID. Everywhere you go. Everywhere you go, care standards have dropped. A lot of senior staff, doctors and nurses have left the industry. And a lot of junior nurses are now in ICU, and that's a big challenge. Big challenge. Care standards have dropped, no matter what someone says. I talk to people that still work in ICU on a regular basis. I employ some people that work in ICU still on a regular basis. The care standards in ICU have dropped. And no one has a remedy to put it back to where it was before. The COVID has put the industry through an earthquake. There's no other words to describe it. And I don't know how we get back to where we were before. If we keep treating healthcare professionals like they're an expendable commodity, people will continue to leave the industry. And COVID has shown, and I mean, we knew that before COVID, that healthcare professionals are not an expendable commodity. It takes years for them to train them. It takes years for them to study, to go into practice, learn all the ropes, so to speak. You could argue that, just for myself, I felt comfortable going public with sharing information about intensive care after I had worked there for maybe 13 or 14 years, and if I had done this after having worked for 5 years in ICU, I'm not sure whether I could share as much knowledge as I could share now. It's just unbelievable that people get pushed out of the industry. We need those people badly. Helen, I know there was a question coming through. You're asking, when Mum was at WSAMCS 4-to-1 in 2016, some of the nurses straight out of school. Sure. Was that in ICU? I can tell you, Helene, my very first ICU, I was working, my very first ICU was in Germany, and there was a 2-to-1, and at some shifts there was a 3-to-1. Unbelievable. Unbelievable. So, Pocket Life Matters asks, my loved one is in a skilled nursing facility right now. He's on a ventilator each evening from midnight to 9 a.m. Although it is a ventilator unit, the facility does not have continuous pulse oximeter monitor, so they don't feel it is... Oh, that's scary. That's very scary if they don't monitor. They don't feel it's safe for him to come off. They use the CPAP setting. Sure. Well, he should definitely be continuously monitored if he's on CPAP. I presume that's very scary, very scary, very unsafe. Well, this is what I've been saying for years. Nobody on a ventilator should be outside of intensive care or outside or not being looked after by a service like intensive care at home. It's the gold standard. It's the bottom line. I mean, it sounds like your loved one is in a scary place here. And I don't know whether your loved one is just on CPAP with a mask or whether he's on CPAP with a trach. Doesn't really matter which way it is. He should not be unmonitored, and he shouldn't be in a skilled nursing facility. It's a New York nursing home. He has a trach. Okay, that's something. He has a trach, but that makes it even more dangerous. How can someone on a ventilator with CPAP and a trach not being monitored? Unless it's his wish. If it's his wish, fair enough. Sometimes patients want that, and that's okay. As long as it's documented. But the way no, it's not his wish, right? No surprises there. You should be asking for their policies. You should be asking for their policies and procedures. You should be asking who's making those decisions not to monitor. I doubt that these people have ICU experience. I very much doubt it. Again, they don't know what they don't know. Yeah, ask them for the healthcare, for their policies, for their standards. Right? Okay, look, I do want to wrap this up slowly. I'll just quickly share with you the topic for next week's live stream. I've got it written down on my phone. I just got to bring it up so you know what's coming next week. Next week's will be, yes, what stages is a patient going through when they're coming off the ventilator? I will talk through the stages. So look, I want to wrap this up. I want to thank you for coming on to the show. Thank you for all your questions and for your participation and for your support. Give the videos a thumbs up, share the video with your friends and families, subscribe to my YouTube channel for regular updates and live streams for families in intensive care. Click the notification bell. If you have a loved one in intensive care, go to intensivecarehotline.com. Call us on one of the numbers on the top of the website or send us an email to support@intensivecarehotline.com. We also, if you have a loved one in intensive care, look at our membership for families in intensive care at intensivecaresupport.org. If you need a medical record review for your loved one, contact us as well. We provide that service too. Thanks for watching. Thanks for your participation. I'll talk to you again next week, and keep an eye on the YouTube, on the quick tips that I will publish this week. Also, if you have a loved one in intensive care long term, go and check out intensivecareathome.com. So where we can help you with home care services, specifically at the moment in Australia, Brisbane, Sydney, Melbourne, especially with NDIS funding, iCare funding, TAC funding, DVA, Department of Veteran Affairs funding, but also private health insurance funding. Thanks again. I will talk to you in a few days. Have a wonderful night and a